Everyone, I'm Ariana Seraphim, and I'm going to be presenting on the article Risk Factors for Maternal Chagas Disease and Vertical Transmission in a Bolivian Hospital. Here is just a screenshot of the abstract for my article. And then if you would like to have the full article, you can scan this QR code. So what is this paper about? So Trypanosome cruzi is the protozoan parasite that causes Chagas disease. So it starts with the bug Tritodonum, and that bug will then go infect, a human or, another mammal. And when they bite them, then they lay the feces on the skin as well. And this is a parasite that leads to Chagas disease. So this article is a prospective cohort study of women and infants in Bolivia at a women's hospital. And the study's aims are to describe the epidemiology of congenital Chagas disease in a high burden setting, to evaluate access to early diagnosis, and also identify risk factors. So, how is this paper relevant to emerging infectious disease? Well, Chagas disease is an emerging infectious disease, despite if you haven't heard of it before. It's been mostly appearing in South and Central America, but it's also in the United States. The bugs are here, and also people who were infected in South and Central America are now living in the United States, and it also can be transmitted to the infants. So here is a nice diagram from the CDC showing the parasite and the bug and the transmission, and how it infects a human. And like I said before, the disease emerges from the Tritodonum bugs infecting humans and leaving their feces on the bite wound. The prevalence of Chagas disease in Bolivia, where my paper is based, over 25% in pregnant women and a 6% congenital transmission rate in live births. According to the CDC, 8 million people are infected in Mexico, Central America, and South America with Chagas disease. And the CDC also estimates that more than 300,000 persons with Trypanosoma cruzi infection live in the United States. And congenital infection has become increasingly an important source of transmission for new cases. So, as we can see, this pathogen is increasing, it's infecting people, so we can say it is emerging. So, who does the pathogen impact? So, it impacts the human that it's infecting. They also may call this the kissing bug. It can also happen congenital infection, blood transfusion, organ transplant, consumption of contaminated food. But this paper that I'm reviewing focuses on females passing the infection on to their infant. As I stated in the previous slide, the population of interest in my paper are women and infants, and just some study details. Again, this was at a hospital, a women's hospital in Bolivia, and 5,828 pregnant women were enrolled, and 6,017 infants were born. And, it's greater than the pregnant women because of multiples, twins, triplets. 1,287 had positive Chagas rapid tests, and 1,325 infants whose mothers were seropositive for Chagas disease. But then 65 total infants, 4.9% of infants were seropositive mothers, 1.1% were diagnosed with congenital Chagas. The study design was a prospective cohort. And how was the data collected? So initially, they did a brief survey to the participating mothers about their medical history, obstetric history, sociodemographic characteristics, and then to look for a Chagas diagnosis. The World Health Organization would like two positive results from two different immunoassays. So they did serologic testing, they did a finger prick, then they also did qualitative polymerase chain reaction. What are the statistical methods used? So, the researchers used descriptive statistics for the overall population and stratified by maternal rapid tests. They used logistical regression to examine predictors of maternal infection and vertical transmission for univariable and multivariable. They use the Wilcoxon ranked sum test and more logistic regression to compare newborn characteristics among infant groups, and then to identify outcomes that were specifically associated with congenital T. cruzi infection. They constructed multivariable models adjusted for potential confounders. And then an interesting point that the authors did that I currently have not done in my research. They set a cutoff of 5% missing data to exclude other variables from the final model. So I was really interested if any of my other students have anything to say about this, if they've done this in a study. The researchers had many participants lost to follow up, so I feel like that's why they were trying to do this. But I thought it was interesting that they removed variables that did not statistically contribute to the model. And if people would think that, this was an interesting thing they did, or if it wasn't the most valid thing they did, and how, it would contribute to the validity of the study. So, yeah, I'm just interested what everyone has to say. So, thank you. So, for the results, there were 1,325 infants whose mothers were seropositive for Chagas disease, but 65 total infants were diagnosed with the congenital infection by qPCR. Among the 5,952 uninfected infants, 1,186 had a 2 cruzi seropositive mother. And among infants with seropositive mothers, 156 returned for a 9-month follow up. So you can see only 156 out of 1,186 returned for their 9-month follow up. So, that's a very interesting point for this study. They really had a lot of participants lost to follow up. So, risk factors for maternal infection include old maternal age, family history of Chagas disease, having seen trichotomine bugs in the home, having ever lived in a home with mud walls, and having ever lived in a home with a dirt floor. And risk factors for vertical transmission in the univariate analysis, previous maternal diagnosis of Chagas disease, family history of it, and having a twin birth. So, what are the possible gaps in knowledge about the topic this paper addresses? What possible gaps does this work fill? So they relied primarily on the diagnosis at 1 month qPCR rather than serology, as the majority of infants did not complete the 9-month follow up. So, there's major concerns about the follow up. And then also, they had some limitations that Bolivian phone numbers are discontinued if not recharged within 60 days. So, they weren't able to reach the participants during follow up. And then also, the article talks about how the difficulties of mothers traveling in Bolivia to come back to follow up visits. So I think they could really, if they do another study, focus on how to, eliminate the loss to follow up, or and how it's a barrier, and how they could better, you know, get the data for this. So maybe in study design, they really need to think about something else on how to, retain participants. Then also, they're limited by self reported data. They also stated that the medical records in Bolivia didn't have like the best system to collect all the information that they wanted. So they had to use self reported data about environmental exposures and medical history, which can be challenging. But the researchers at the end of the article stated, this was a positive study, they were able to have a laboratory in the hospital to have qPCR um, analysis with the blood samples, and Chagas is also not always prioritized in these countries that don't have the technology and the laboratory resources. So it was important that this laboratory was there to properly diagnose infants that maybe would have been missed if this study, didn't occur. So I think from a public health standpoint, this was really great to kind of just get more infants diagnosed so that way they can have proper treatment for Chagas disease. I just want to thank everyone for listening to my presentation. I really appreciate it. I'm looking forward to what everyone has to say about it in the discussion and discussing more about, how the researchers could have improved the loss to follow up in their study design and also their statistical analysis plan, and also, how to work with countries that don't have the best medical records and how to accurately get self reported data. So, looking forward to hearing from you all. Thank you so much for listening to my presentation.